for joining our ACNN YNN webinar today. So, do we have a moderator? Mai and also Nanae. Let's start, I think. Evelyn?
Hi. Good evening, everyone. I'm Dr. Evelyn Vela Rojas from Peru. I have a great honor of chairing this first session. It's my pleasure to introduce our distinguished speaker, Professor Alberto Ramirez Espinoza. Professor Ramirez is a senior neurosurgeon from Peru with over 25 years of experience in pediatric neurosurgery. He completed his neurosurgical postgraduate training at the National University of San Marcos, pursued a fellowship in minimally invasive neurosurgery, neuroendoscopy, neuronavigation, keyhole techniques at the Prince Wales Private Hospital in Sydney, Australia. He currently serves as chief subunit specialty neurosurgical care at the National Institute of Children's Health San Borja in Lima, Peru. In addition of his clinical role, Professor Ramirez is deeply involved in medical education. He is a coordinator of the microneurosurgery and pediatric neurosurgery course for the neurosurgery residents at the National University of San Marcos. He also leads a pediatric neurosurgery specialty program at the same institution. He is an active member of the International Society for Pediatric Neurosurgery, the Latin American Neuroendoscopy Group, and full member of the Peruvian Society of Neurosurgery. As a researcher and educator, Professor Ramirez contributes numerous publications and international presentations on topics such as pediatric brain tumor, neuroendoscopy, craniofacial surgery. Today, he will share his insight on a very important topic. Please, Professor Ramirez.
Good night, good evening, everyone. Thank you for the invitation. Dr. Chani, Professor Yoko Kato, Matron Ji Cheng, and Dr. Evelyn Rojas, and the Asian Congress of Neurosurgical Nurses. Yeah. Well, this topic is pediatric brain tumors. My name is Alberto Ramirez Espinoza, neurosurgeon, chief of neurosurgery in the National Institute of Children's Health San Borja in Lima, Peru. We have completed 12 years saving life in Peru since 2014. We have been on the rise in the number of surgery performed in the neurosurgery service, reaching a maximum in 2018, with a progressive fall due to the pandemic until recovered from 2022 progressively. We are a multidisciplinary team that has shared the care, evaluation, treatment, and recovery of our neurosurgical patients. Mortality in the neurosurgery hospitalization in my institute has been 0.7% in 2024. Today, I'm going to present the experience of the Institute in the treatment of pediatric patients with brain tumor. Talking about the whole theory of brain tumor in pediatrics would be talking longer than the established time. So we will talk about our experience mainly. The pediatric brain tumors is the second most prevalent kind of cancer or most frequent type of solid tumor in pediatric. 5.67 cases per 100,000 person years. Malignant and non-malignant brain and other CNS cancer in children and adolescents in the USA. Most common Most common solid cancer in leading cause of cancer death in children. 0.72 death per 100,000 newborns to 14 years old in the USA. The risk of factors for developing brain tumors in pediatric are many, such as neurofibromatosis type 1. It's the most frequent syndicate cause of gliomas in patients. The second cause, tuberous sclerosis, is an illness neurocutaneous disorder. Subepidemial giant cell astrocytomas are more characteristic. The presence of tumors in the brain, eyes, kidneys, heart, lungs, and skin. Leaf-Raumenis syndrome is a hereditary genetic condition that significantly increases the risk of developing certain types of cancers, such as sarcomas, brain tumors, leukemia. As for the diagnosis, the clinical picture is presented according to the location of the tumor. A specific place at a subprotectorial level generally can give intracranial hypertension, motor deficit, seizures, visual alterations, vomiting, and in the posterior fossa can also give ataxia, dysmetry, and compromise of cranial pairs. Depending on the age of the patient, if he is a newborn, he may also have macrocephaly, some rising sign, the scalp collateral circulation, tense fontanelle. The clinical picture will also depend on aggressiveness, which has the tumor that grows very quickly, and the symptoms will occur in a short time. The evaluation should always be interdisciplinary. Pediatricians, pediatric oncologists, and in selected cases, pediatric neurologists. The clinical presentation in children is intracranial hypertension, headache, vomiting, drowsiness, papilledema, seizures, lethargy. In infants, developmental delay and failure to thrive, increased head circumference, vomiting, bulging fontanelles, and sunset sign, macrocephaly, papilledema, or atrophy. Images for decision making are important. We have a CT scanner, resonance, and cineangiography. The CT is MRI is not available or in cases of emergency. The MRI with contrast imaging of choice is not an emergency, including navigation. Whole spine is necessary in almost all cases for staging reasons. May be useful in selected cases of highly vascularized tumors. This is a tumor, pleomorphic astrocytoma. They usually occur in the cerebral hemisphere. The upper section of the brain is a brain tumor grade 2. Almost 70% of children with these tumors have seizures, intracranial hypertension, hemiparesis, behavioral change. In the MRI that I show, you can see a tumor occupying the left ventricle, the left lateral ventricle with great deviation from the midline and with great vascularization. This is a CT scan with a patient with a posterior fossa tumor. There are many tumors in the pineal region, in the cellular region, in the cerebropontin angle, and then in the postoperative images, you can see the brain tumor in the CP angle, in the left temporal lobe, in the cellular region and the pineal region. This tumor was a mixed brain teratoma and complete with a spinal cord MRI. And you can feel the presence of the tumor in the spinal cord. It's a pity in this patient. The goal of the treatment in patients with brain tumor is completely remove the tumor, partially remove a malignant tumor, obtain a sample of tumor whose etiology is not known, treat hydrocephalus. Intraoperative considerations or preoperative management is important. Extensive and thorough communication with parents and caregivers is very important. The informed consent. The child should be informed in an age-appropriate fashion. Preoperative blood work, hemoglobin, electrolytes, coagulation, type, and screen. Neuroanesthesiology evaluation, preoperative steroids, antiepileptic medication is indicated for suspect of diagnostic seizures. If hydrocephalus is present, EVD placement or ETB. It depends if you have a neuroendoscope. Intraoperative considerations, neuroanesthesia is important. Anesthesiologists experienced in pediatric anesthesia with neurosurgery patients with adequate control of the temperature, above all in younger children. Is also important the cranial fixation in older children to be able to change the position of the head through the operating table during surgery. We can also use important state-of-the-art equipment, such as neuronavigation, and thus do a minimally invasive surgery and avoid greater blood loss, which is an important factor in pediatric patients. The head fixation, head holder Mayfield, to pterional approach, posterior fossa approach, and retrosigmoid approach. Now, we will see some examples of patients with tumor in which we have been able to perform total removal of the tumor. This is a patient who is 9-year-old, operated for choroid plexus carcinoma. In a preoperative brain MRI, you can see a left ventricular tumor with solid and cystic component with midline shift, which was operated on with a left temporal craniotomy and was gross total resection, as can be seen on a postoperative brain MRI. 1-year-old patient with a typical teratoid rhabdoid tumor who was operated through the left frontal craniotomy with a total resection of the tumor, but because it's a very malignant tumor, grade 4. A month later shows tumor recurrence. You can see in the postoperative brain CT 1 month later, it's a kind of tumor of difficult oncological treatment in pediatric patients. Soon we will publish a series of cases of 14 patients with atypical teratoid rhabdoid tumor, of which 8 were supratentorial, 5 posterior fossa, and 1 in spinal cord. You can see the video during the surgery. This is the article. Another case of 1-month-old patient with right high-end immature teratoma. We see the high-end tumor in the right temporal parietal in the preoperative CT. The tumor was completely resected, as can be seen in the postoperative MRI. In the video, you can see the surgical act with a dissection of the tumor under surgical microscope vision. In Peru, in the last 5 years, many cases with brain sarcoma have appeared, becoming the most frequent emergency tumor surgery in our institution. As we can see in the pre-surgical CT, we have a contrast captain tumor image in a 9-year-old patient who underwent surgery with a total resection with a good evolution. They are aggressive tumors with a short time of illness and considerable intraoperative bleeding. This is a patient, 2-year-old, with Ewing sarcoma, presenting a large right retroauricular tumor. Total resection was achieved, as we can see in the images. Meningioma is another tumor in pediatric patient too. Meningioma of the left ventricular atrium, in which total resection was achieved. You can see the video during the surgery using neuronavigation to planificate the surgery, the craniotomy, and the postoperative brain CT, no tumor evidence. This is another meningioma. Left part is located in the atrium. Total remove in the post-operative brain MRI. This is another case, posterior fossa pilocytic astrocytoma in a 11-year-old patient, grade 1, according to the WHO, World Health Organization. As we can also see in the preoperative MRI, there is a large cerebral tumor. After having undergone surgery, we can confirm that postoperative MRI that the resection was complete. This coronary plexus papilloma, grade 1, pardon. And another case of posterior fossa was pilocytic astrocytoma, 11 years old. You can see cerebellar edema and heterogeneous lesion that enhance the contrast. The total resection is confirmed in the postoperative MRI. Another pilocytic astrocytoma of posterior fossa in a 4-year-old patient with total resection. What tools do we have and the institute to be able to operate on children with brain tumors? We will have neuronavigation, as we see in this case, that is a deep tumor, mixed germ cells at the level of the basal ganglia. Thanks to the location with neuronavigation, we were able to achieve a total resection in a postoperative study after 2 years. We confirmed that the patient is free of disease. In the photography, we see the operative piece of the tumor. The neuronavigation allows us to locate the tumor lesion, perform the best craniotomy, determine the trajectory through which we will remove the tumor, reducing blood loss, operative time, and the possibility of neurological sequelae. We can also rely on the use intraoperative ultrasound. Like in this case, you see the tumor with use neuronavigation, intraoperative ultrasound, a small craniotomy, thanks to the navigation. This is another example with right ventricular ependymoma, in which we use neuronavigation to perform the surgical approach, achieving total exeresis. This is a big tumor in the left ventricular side, and total remove in the postoperative brain MRI. Using minimally invasive surgical techniques, such as the approach through the eyebrow, in which is medial modification in a patient with a right frontal low-grade glioma. Using intraoperative ultrasound, we achieve the resection of the lesion. In the postoperative MRI, you don't see the tumor. This is the intraoperative ultrasound, previously resection, after the resection. The ETV is important for the hydrocephalus treatment. Another of the equipment we use in the treatment of hydrocephalus is the neuroendoscope. We perform endoscopic ventriculostomy in obstructive hydrocephalus due to brain tumor, as well as perform biopsy of ventricular tumors. In the video, you can see how an endoscopic ventriculostomy is performed, in which we can see the basilar artery, which confirms the success of the procedure. Using the biopsy ranger, you do a hole. After that, using a Fogarty balloon, all these videos are of my institute making the neuroendoscopy. You can see the basilar artery. ETV mass tumor biopsy. In this case, is a tumor located in right ventricular, near the Monroe foramen. The endoscopy biopsy and septostomy were performed. The anatomopathological result was oligodendroglioma. In the preoperative CT scan with contrast, this is a pineal region tumor with hydrocephalus, germinoma, and in the previous preoperative CT scan with contrast, do ETV plus biopsy. The patient has a complete tumor remission, the clinical picture of intracranial hypertension. This case is la oligodendroglioma near to the right foramen. You can see in the video of the neuroendoscopy, biopsy of the tumor, and after that, do the cystectomy. We have iScolab neuroendoscopy. And this is the cystectomy. In the postoperative MRI, brain MRI, no more hydrocephalus. The tumor is located near to foramen, monoforamen. This is the other side in the video. You can see the choroidal plexus. The post-surgical complication that patients operated on for brain tumor may present a brain edema, hemorrhage in the operating bed, neurological deficits according to the location of the tumor, cerebrospinal fluid leakage, seizures, pneumoencephalum, and including death. What is the future in the diagnostic and treatment of brain tumor in pediatrics? Expand molecular studies, new tumor markers that improve diagnosis, development of individual tumor-specific expression profiles predicting response to therapies, and novel therapeutic approaches. The final success of the treatment of pediatric patients with brain tumor is the result of teamwork from the patient's entry into our institution until he is or she is discharged. Neurosurgeons, anesthesiologists, pediatricians, intensive care physicians, pathologists, nurses, technicians, nutritionists, psychologists, physical therapy, chemical pharmacists actively participate. Muchas gracias. Thank you very much.
Thank you very much, Professor Ramirez, for that very informative lecture. I would like to invite our commentator, Professor Waller, for any question or comment.
Yeah, Professor, it was a very nice lecture. I would just like to know, where do you use DSA? Or in which cases you use DSA and angioembolization? In which kind of tumors, basically?
Embolize a kind of tumor. It has good vascularization, like meningioma, maybe. Like a case that shows xanthosarcoma pleomorphic xanthosarcoma.
Yeah.
It depends on the age of the patient in the vascularization of the tumor. And a few cases are embolized.
Okay. Otherwise, very, very useful lecture. Yeah.
Oh, thank you.
And what about the Ewing sarcoma you have done? A case you have shown of Ewing sarcoma.
Brain sarcoma in Peru?
Yes.
We have not explication why the cases of sarcoma in Peru increases in the 15 years. Not yet, not yet, but it's the more frequent tumor in emergency. It appears with hemorrhage, midline shift, great edema. Is emergency surgery using this compressive craniotomy, because edema, postoperative edema is terrible in this patient. And my institute has a tissue bank, put the bone until the edema reduce. Another question?
Evelyn? So another commentator you can invite.
Dr. Simon, please.
Yes,
Okay,
thank you so much. I would like first of all to congratulate Professor Ramirez for his wonderful presentation. So I'm Simon from Congo DRC. I'm a nurse practitioner. So I have two questions. Professor Ramirez, in your institution, what is the rate of recurrency? That is the first question. The second one is for how long do you keep the patient intubated after the surgery?
Oh,
And the third one is, do you send the patient directly in the ward after the surgery, or you refer him to the ICU?
oh. It depends on the stage of the patient. First of all, the patient is good score. The patient entered to the hospitalization, prepared to the surgery with useful prepare the patient with electrolytes, hemoglobin, another tests, with help of pediatricians. After that, the patient is going to the operating theater. And after the surgery, the patient enters to the ICU care, ICU neurosurgical care. We have 10 beds with ICU or medical intensives, medical physicians with experience in treatment of the neurosurgical patients. Is clear?
Yes, it's clear. Muchas gracias.
Muchas gracias.
I have a question for the audience. Silvia Masabe say, thank you, Professor Alberto, for such education presentations. And what stage of the tumor you consider total resection?
This is a good question. To consider total resection with the tumor is not near to the eloquent area. It's not located in eloquent area. It's important the patient stage, the stage of the patient, the vascularization, maybe in some cases make 2 or 3 surgeries to remove all the tumor. First of all, the first surgery I have the diagnosis. If the tumor is treatment tumor, remove in the second or third surgery, it depends of the large of tumor, the vascularization, the time in the operative theater. It's important the large of the tumor, the vascularization that I say. That's okay?
Hello.
Erin? Yes, please go ahead. Hello?
Hello?
Mr. Shamu?
Okay, thank you so much. Thank you so much, Professor Alberto, for your very insightful presentation of the experience at your hospital. As we know, this particularly astrocytoma tumors, they're more devastating and life-threatening. But when you see on your mortality rate is almost negligible, which is 0.7. Compared to one study which showed that this astrocytoma is 7.4, is the highest cause of mortality death. Can you give experience? What have you achieved that much to reduce this death?
That's 0.7% of mortality in my service is in all the patients, not only tumor. The most important problem that we have is only my institute is for surgery patients, pediatric patients. In Peru, there is another institute for cancer, but we have a good communication through the WhatsApp, mail with other institutions because of the patient needs a Zoom treatment for the cancer, and the patient is reference to the other institute for cancer for the medical treatment and after the surgery, after discharge in my institute.
Okay, thank you so much.
Khadija? Khadija, please.
Thank you very much, Professor Alberto, for the nice presentation. My question is, you have a specific time for the posterior fossa tumor excision to be intubated.
Can you repeat again, please?
Do you have maybe a specific time you are considered for the posterior fossa tumor to be intubated after excision, tumor excision?
And the brain tissue, edema?
No,
Or
the tumor excision, posterior fossa tumor excision. Maybe because of the brain edema after surgery, maybe you have considered a specific time the patient still intubated until the edema subsides. Maybe do you have a time specific, or you extubate the patient after surgery?
about the ETB? No, can you
Endotracheal tube intubation.
intervention? And in the
Yeah,
patient, a tumor, posterior fossa
patient
tumor.
with a, yes.
Yeah. Maybe the operate the patient if prone position inside a midline occipital through the C1 incision through dissection the part tissues and craniotomy occipital telovelar approach, and then remove the tumor, part of the tumor sent to the biopsy with response soon. This is a malignant or benign tumor. After that, continue to remove the tumor, the total tumor if possible, if it's possible. Then the treatment of hydrocephalus in this kind of patients it depends of the stage of the patient. If the patient tolerate the hydrocephalus, in the put EBD intraoperative time, previously to the tumor surgery, or if it's possible, make a ETB. It depends on the patient. In the moment, the stage, the patient, the clinical picture.
Okay. After surgery, posterior fossa tumor, they have a tend to develop brain edema.
Oh.
So because
Yes.
of brain edema, they have a respiratory arrest because of the brain edema.
Yeah.
So maybe my question is, are you preferred to be patient to be intubated until the edema subsides before deciding to extubate the patient?
Yeah, good question. In the surgery, we have a cerebral edema. We cannot put the bone. Yeah.
Okay.
For the treatment of the edema, and then the patient go into the ICU care. After that,
yes.
maybe do a CT scan, and then if the edema, cerebral edema, is not longer, you can see extubate. You can do extubate.
Extubation. Thank you very much, Professor.
Professor?
Okay.
Yeah. Do you prefer doing a VP shunt in posterior fossa tumors prior to doing a surgery, main definitive surgery, or you directly go ahead with the main definitive surgery along with the EVD placement during the surgery?
Can you speak slowly, please?
Do you prefer doing a VP shunt before definitive surgery, ventricular peritoneal shunt before a definitive surgery for posterior fossa tumors, or you go ahead with the external ventricular drainage system at the time of surgery itself?
Oh, good question. Prefer put EVD first of all. Some type of posterior fossa tumors are located in the left or right side. When you remove the tumor, there are possibility the hydrocephalus is resolved. But when the patient is in hospitalization, we do retype protocol, elevate the EVD at 10 centimeters per hour, 15 the next day, 15 centimeters per hour, 20 the next day, 20 centimeters per hour, and then close. If the patient has no symptoms, do a CT scan and confirm no hydrocephalus, and after that, remove the EVD. If the patient has a symptom and the CT scan shows hydrocephalus, put a ventricular peritoneal shunt, or the alternative, the ETV.
Evelyn or Matrini, are you joining us now?
Professor Ramirez, based on your experience, what do you consider the best surgical option for treat the hydrocephalus and posterior fossa tumors in pediatric patient that refer from the hospital than labs or the pediatric intensive care?
The best treatment for the patient with posterior fossa tumor is difficult to decide. Too difficult to decide. I not prefer ventricular peritoneal shunt because always is present the possibility of metastasis, peritoneal metastasis, always, and another complication of BP shunt. If the patient is benefit with ETV, do ETV or remove the EVD if possible.
Do you prefer ETV and BP shunts in hospital for the next refer on your hospital?
Maybe, but I prefer no shunt, no treatment like hydrocephalus. The patient shouldn't depend of the BP shunt or treatment of hydrocephalus. If possible to remove the EVD, is excellent result. You eliminate all the complication for a surgery or for BP shunt.
Okay, thank you. I have another question of the audience. Simon Ilanga. Dear Professor, what is the rate of the site infection in your institute of the BT resection of the other?
Oh,
the rate of infection.
Not. I haven't got the exactly rate, but we have a important process to do a surgery. The clean hands is very important in my institute. Previously touch the patient in the room of the patient, in the 5 steps of the hands, clean hands. In the operative theater, we clean my hands and my colleagues cleans their hands in 5 minutes. We have only clean that we have do the clean the skin of the patient to avoid the infection, postoperative infection in the patient. I haven't got the rate exactly, but it's possible to infection in the wound, in the CSF, fistula or CSF leakage. It's possible, but exactly the rate we have it.
Regarding regarding of the brainstem tumor, have more cases in your institution? Brainstem tumor.
Can you repeat the question, please?
About brainstem tumor.
Brainstem tumor. I show you a slide with teamwork. The consultants in oncology pediatricians is very important. When the patient has a brainstem tumor, we have a meeting about the case and decide if the patient is possible to do biopsy for the diagnosis. But if the meeting of specialists, mainly oncology pediatricians, said not more, the patient is referenced to another institute of cancer for by oncologist treatment. To oncologist treatment.
Okay, Prof. Alberto, thank you very much for the very informative talk. Can Dr. Evelyn just do a closing remark for the first session? We would like to start the second session. Thank you very much.
Thank you very much for inviting me. Thank you, Dr. Evelyn Judy Rojas. Thank you, ACNN.
Thank you.
We do good work in my institute for the attention of pediatric patients, mainly brain tumors. Thank you.
Thanks, Prof. Alberto.
Yes, thank you so much for your great lecture. Thank you so much. So maybe we can collaborate in the future. Thank you very much. So in next week, Evelyn will come to my institute. Now she's in Japan. Yes.
Wow, thank you. Thank you.
Good luck. Thank you so much. The nice lecture. Thank you very much.
Yes, see you.
Can I call upon our nurse practitioner, Mai Okobo, to introduce the second chair, please?
Okay, thank you, Matoi. So I would like to introduce this second session chairman, Miss Nimula Ramu from India. So please, could you continue, Madam? Oh.
You are muted, I think.
Mrs. Nimala, can you please unmute yourself?
Am I audible?
Yes, yes.
Okay. Good afternoon, Professor Yoko Kato and Matron and all others present here. It gives me great pleasure to extend a warm and heartfelt welcome to each one of you to today's webinar organized by the ACNN. And on the topic, important topic, that deeply meaningful topic, that is care of children with brain tumors, the nursing perspectives. As the chairperson of this session, I feel truly honored to chair such a gathering of passionate educators, professionals, researchers, and students who are dedicated to holistic care of our vulnerable patients, that is children battling brain tumors. Today's session aims to bring forth varied nursing perspectives drawn from evidence-based practice, real-world experience, and interdisciplinary collaboration. We are privileged to have with us Mrs. Vijitha, who is a neuro nurse working in the Sri Chitra Tirunal Institute for Medical Sciences and Technology, Trivandrum, Kerala, She's working in the neurocritical care unit for the past 9 years. She's a postgraduate from Kerala Health University with first rank. So I encourage each one of you to actively engage in the session, ask your questions and share your reflections at this platform. And as it is not for learning, but for growing together as a community. On behalf of ACNN, I thank you all for your commitment and presence today. Let us continue to inspire, learn, and empower one another in our shared mission of delivering the best care possible to children with brain tumors. Now I invite the speaker, Mrs. Vijitha, to present your topic on nursing perspectives of children with brain tumors. Over to you, Vijitha.
Thank you, ma'am. Am I audible to all?
Yes.
I am very happy to be here, and thank you so much for inviting me to present such a wonderful and knowledgeable topic. So we can see the pediatric brain tumors nursing perspective in detail. Pediatric brain tumor is the most common type of solid tumor in children, which can be either malignant or benign. According to the combined data analysis from 2008 to 2017, the incidence rates for malignant brain tumors and other CNS tumors in children and adolescents increased from 0.5% to 0.7% per year, whereas those in all other age group is decreasing. The nurses plays a vital role in caring for a child with a brain tumor by providing comprehensive and compassionate care. We can see the pediatric brain tumors through the eyes of nurse through the coming slides. It has different layers. It includes the nursing roles and responsibilities, nursing challenges and coping strategies, and future direction in nursing care. First of all, the nursing roles and responsibilities, which include the nursing assessment and diagnosis, monitoring and ongoing care of a child with increased ICP, child underwent surgical management, and child on chemotherapy and radiation therapy. Along with that, one of the most important aspects is the family education and psychological support. We can see each one in detail. The initial assessment includes collection of medical history and physical examination. The signs and symptoms of brain tumor in child may be vague or similar to the symptoms of many childhood illness or common developmental pattern. The signs and symptoms of brain tumors are depends on its size, location, and growth rate. So as I said earlier, sometimes we cannot predict the signs and symptoms of brain tumors. Why? Because it can mimic other childhood illness. Sometimes it can mimic other normal developmental pattern. For instance, a child with hypothalamic hematoma was admitted in our hospital. The key feature of hypothalamic hematoma is gelastic seizure. It is nothing but the child will simply laugh without any environmental cues. As we all know, the social smile starts to develop by 2 to 3 months. So the parents thought that it is normal. So it is normal developmental pattern. So they didn't bother about that. By the age of 1 year, they came to know that it is not normal. It is something abnormal. So they approached a neurologist and it is found that it is hypothalamic hematoma. So here lies the significance of understanding in deep what is the signs and symptoms of brain tumors. Then the signs and symptoms varies depending upon where it is getting located. For instance, if it is in the neurohypophyseal region, the sign may be either visual field defects or any kind of endocrine abnormalities. If it is in the ventricle, the symptoms may be increased intracranial pressure due or features of obstructive hydrocephalus. Sometimes it may be manifested as ataxia or visual disturbances or cranial nerve deficits if it is in the posterior fossa. So depending upon the area where it is get located, depending upon its growth pattern, the manifestations will vary. Next is about the diagnostic tests and procedures. A lot of diagnostic tests and procedures we have seen in last session. Among them, the MRI is considered as the gold standard in diagnosing brain tumors in children. Here, we know that the diagnosis is made by neurologist or neurosurgeon. But what is the role of a nurse? A nurse is the one who is preparing a child as well as the parent for undergoing any kind of diagnostic procedure. So the key areas of concern is that the child may get anxiety. Sometimes they will be very fragile. Emotionally, they may be very fragile to undergo such kind of investigations. So the nurse should be there with the child, and if the child is mature enough to understand what we are saying, we should have a good communication with the child as well as with the parent. For instance, if the child is undergoing for a MRI, for normal adult, it is somewhat an unpleasant experience through going a MRI scanner. So for children, so it will be some more difficult to undergo through an MRI scanner. So what a nurse has to do is either for infants and very young children, we will give some kind of anesthesia. But the child who are some sort matured, what we have to do is we have to have a good talk with the children and we have to prepare them mentally to undergo the procedure in a good way. Next is about the monitoring and ongoing care. Once the diagnosis has made, we know that the nurse is with the patient for 24 hours. So any change within the patient, within the child, can be easily identified by the nurse. The monitoring and ongoing care is different in different cases. First, if the child is getting admitted with increased ICP due to any kind of complication from brain tumor, what a nurse is supposed to do? First is monitoring. Monitor the neurological status of the patient, ICP, and respiratory status. Positioning of the child in by elevating the head for 30 to 45 degree and by providing a neutral head position. Airway management is very important. Adequate oxygen saturation should be maintained. If the child is in the ventilator, in order to optimize a PaCO to around 35 to 40 mm of Hg, continuous monitoring of continuous monitoring of ABG, SpO2 is mandatory. Administration of medications like osmotic agents, steroids, analgesics, sedatives, anxiolytics are paramount. Fluid management is mainly focusing to maintain euvolemia. Along with that, a strict intake-output chart has to be monitored. Temperature management is also very important. Along with that, the more important thing is the child is more prone to get seizures. So the seizure precaution is very important. Pad the side rails, keep suction and oxygen supply available. Never leave any child alone and administer the prescribed anti-seizure medications at correct time with correct dosage. Then if the child have any chance to get increased ICP, it should be keep in mind any kind of stimulus which can increase the chance of ICP has to be avoided, like avoid straining, minimize environmental stimuli, and prevention of infection. This is about if a child is getting admitted with increased ICP. The other scenario is if the child is getting admitted for any kind of surgical management. As we all know, from the time of admission till the surgery and during the surgery and after immediately they are shifting to the intensive unit till the discharge, the nurse has a significant role. The preoperative preparation is same as that for any kind of other general surgeries like physical, psychological, emotional, legal. Plus, the most important thing is family education and proper communication. Once the preoperative care has done, we will receive the patient to the intensive care unit. The first 24 to 48 hours is very, very critical. So whatever we have done, if a child is getting admitted with increased ICP, everything we should put into practice if the child is receiving immediately after the surgery. Along with that, pain management, fluid electrolyte management, plus the care of surgical wound and prevention of infection is very, very important. The surgical site has to be checked then and there and maintain a sterile technique in which the hand washing is very, very important. Plus, the respiratory care and gastrointestinal care is to be done by nurses. This is the general care a child should be received. When we go into deep, there are some specific nursing care a nurse has to be rendered for different kind of tumors. Generally, we know that a simple classification of pediatric brain tumors are depending upon its location, that is supratentorial tumors, posterior fossa tumors, and infratentorial tumors. Depending upon where it is getting developed, the care will be different. General care we have to give. Along with that, a specific nursing care has to be given by a neuro nurse. For example, we can see what are the things we have to see if the child is having supratentorial tumors. If it is an intraparenchymal tumor, definitely there is chance of seizures. So seizures has to be monitored. Along with that, focal neurological deficits, hemiparesis, visual changes, speech or cognitive changes have to be monitored. Along with that, seizure precaution has to be done and mobility and functional support to be given to the child. If it is an extra-axial tumors like choroid plexus papilloma, there is increased chance of getting hydrocephalus. So what a nurse has to do is, if there is any kind of signs and symptoms of hydrocephalus like sun-setting sign or increased bradycardia or increased systolic BP, any changes in the pupillary size, these are things have to be monitored every hourly. Then if it is an epidermoid cyst or dermoid cyst, monitor for seizure and cranial nerve dysfunction. Then the main area where the nurse has to put more effort is the supracellular and supracellular lesions. Here, the child will go, the fluctuation of sodium and water imbalances is unpredictable. So the nurse has to be vigilantly monitor the intake output chart every hourly. Sometimes the child may be in DI or sometimes the child's output will be very, very less. Depending upon that, the sodium level and serum osmolarity can be changed. So every fourth hourly, the serum sodium, serum osmolarity, and every hourly, the intake output chart has to be maintained. Along with that, if the child is having any kind of panhypopituitarism, a long-term need for hormonal supplementation is there. So the child as well as the parents has to be informed about the need of such kind of hormonal supplementation. Then, if it is a posterior fossa tumor, the scenario is different. So, the nurse has to monitor for ataxia, poor coordination, cranial nerve deficits, like sometimes it may be manifested as difficulty in swallowing. So, what a nurse has to do is put an RT. Usually, the child will be in RT, and the nutritional needs has to be met by each nurse attending the particular child. Then monitor for signs of hydrocephalus. As we have seen in last session, the chance of hydrocephalus in posterior fossa tumors are very, very high. So we have to have a look on the signs of increased ICP as well as increased hydrocephalus. Then in 20 to 40% of children after posterior fossa surgery, they may get posterior fossa syndrome. It is very rare, but it can occur in children. So we have to monitor for any kind of speech abnormalities or lack of speech like mutism or emotional lability, ataxia or hypotonia. In such cases, coordinate for supportive care like speech therapy, physiotherapy and occupational therapy. This is all about the posterior fossa tumor. In infratentorial tumor, the chance of seizure is very, very less, but we have to have a look for seizure also. Along with that, the most important area is the chance of increased vomiting, headache, and increased CSF production can cause hydrocephalus. So prepare the child for CSF diversional procedures. It is not complete, but the most common type of tumors and the most specific cares, depending upon the tumors, I have narrated here. Any other tumors are there, but the most common tumors I have explained here. Next is, once the surgery has done, the child may go for either chemotherapy or radiation therapy if it is needed. Pediatric oncology nurses play a crucial role in chemotherapy administration, requiring specialized knowledge skills to manage the unique needs of children with cancer. The role of nurse while caring of a child with chemotherapy include administration of chemotherapeutic agent, monitor side effects, focus on the overall well-being of the child as well as family support. The most commonly using chemotherapy drugs are temozolomide, cisplatin, carboplatin, lomustine, vincristine, and cyclophosphamide. Along with that, we should have a look on the side effects of this chemotherapeutic agent. As we all know, the common side effect is bone marrow suppression. So the child will be more prone to get infection or any kind of bleeding. So we should look for the activities of child, the vigorous play a child should not do after a chemotherapy. And along with that, the chance of getting infection is more. So the child should be cared in a way to prevent the infection and to avoid another complications due to the chemotherapy. Along with that, there is chance to get growth and delayed growth and delayed puberty, especially if the child is getting long-term chemotherapy. Children's brain are more sensitive to neurotoxic effects. So it can manifested as some problems in, it can manifested as some psychosocial problem or emotional problem, as well as it can arise as challenges while they are going to school. These all about the main roles and responsibilities. But a challenging area for a nurse while caring a child with brain tumor is family education and psychological support. Let me share with you two experiences that I had. First one, it is a child of 13 years is admitted to the hospital, and on the after the surgery on 14th day, the histopathology report has come and it is found to have grade 4 tumor. And the child's mother was very anxious. She lost by herself and she was stuck there for a short period of time. Only evidence was there, a full of tears in her eyes. Nothing was there. The irony is that the child's mother was a nurse. What we expect is the nurse can accept and she can understand what is the situation. She can think in the reality. But the opposite of that was happened. It is the first scenario. Second one, it is a child, a very younger mother of a child diagnosed as medulloblastoma. He is only 3 to 4 years of age. He underwent for multiple surgeries. At the end, the mother came to know that his child is going to die within few days. So the mother was very, I don't know whether she was practical or by continuous effort she became more mature emotionally and she accepted the reality. In the two cases, what we can say is the two extreme ends of the emotional spectrum of parents. So, as a nurse, there is no specific formula or there is no specific method or there is no specific approach to care each parent. Each parent is unique, each child is unique. So whatever we have seen, if the child's in ICP is increased, there is a protocol to implement. But in order to care the psychosocial aspect, there is no protocol. This is the challenge of nurse. So a lot of practice we can make to overcome such challenges like through proper communication, referring them for palliative care services, act as an educational resource person to give more care, how to take care of child once they have underwent for surgery, or once they have received any kind of chemotherapy or radiation therapy, or we can ease the hospital transition of the parent, as well as we can help them for long-term follow-up. These are the some approaches which have good results. These all are the roles and responsibilities of a nurse. Next, we can see what are the nursing challenges and coping strategies. By continuing the last aspect that I have discussed, one of the challenge a nurse confronting on daily basis is the sorting of psychological aspects of parents. Along with that, it is a complex medical issue. So where a lot of physical, emotional, and psychological investment a nurse has to put. Plus, sometimes it is a long-term care. A child who has admitted for the first time may get admitted many times. So it is a long-term follow-up. The challenges are more, but the coping strategies is very, very less. It is the one of the key area the nurses has to be addressed and to be explored. What we can do is we can have an open communication with the parent as well as with the child if the age is appropriate. Along with that, what we can do is we can give a good emotional support to the parents as well as to the child. Let them ventilate, be silent, and let them ventilate what they are feeling. Plus the education from our own experience, we can educate them what is expecting in the future, what are the opportunities, treatment opportunities are available, and we can act as advocate for getting good care to the children by referring them, by helping or by act as a collaborator in a multidisciplinary team. Next is future direction in nursing care. So we have seen that a lot of challenges through which a nurse has to go while caring for a child, while caring an immature child with a mature parent. So a lot of areas has to be explored. A lot of areas has to be solved. So for that, the nurse has to be actively participate in nursing researches, effective clinical nursing researches. It can make good impact on the clinical practices, which can make strong evidences, which if we are putting such kind of evidences into practice, it can make definitely good difference in the recovery, overall well-being of the child. So these are about the presentation. Thank you.
Thank you, Vijitha. Vijitha has presented it in a very elaborative way, how to take care of the child in the pre-operative period as well as in the post-operative period. And definitely, of course, we have to take care of the parents. So the pediatric neuro-oncology is a field that is challenging, as not only it's clinically challenging, but it is emotionally as well as ethically it is challenging. And nurses, of course, nurses play a pivotal role in this journey, from recognizing the early symptoms of the disease to the management of side effects, as well as continuity of care. Most of the time, they have to continue the treatment for a long time. Repeated admissions may be required, repeated surgery may be needed. In such cases, the nurses has to give support to the child as well as to the family members. So over to you, ma'am, for your comments.
Prof, do you have any comments, Prof?
Yeah, it was very nicely presented by Sister Vijitha. You have almost all covered almost all the areas and giving specially importance to the parent counseling and communication, as well as the role of giving affectionate care to the patient. Nurses plays a very vital role, especially in the preoperative area also, while doing an investigation like MRI. And these patients are very claustrophobic. Pediatric patients are very usually claustrophobic, and the fear of getting detached from the parents. Nurse plays a very vital role. Similarly, in the postoperative period, to give a to find to see the patient at the earliest, and to locate, to identify the features of raised ICP, as well as the electrolyte imbalance. Nurses play a very vital role. Very nicely covered lecture. Yeah.
Thank you, Prof. Kala. Shimo, have any comment?
Okay, thank you so much, Ms. Vijitha, for the very wonderful and a great job that you've made. I would like to congratulate you on the good presentation that you made today. I learned a lot from you, but also, as we know, you are a whistleblower for any condition changes and all care concerning the patient, particularly past the postoperative. But I would like to know, I would like to ask a little bit a question concerning the, after the patient has been discharged, what are mechanism of follow-up you made, particularly to this patient, maybe they don't have recovered well on perspective of physiological activities.
Do you want to know about the follow-up? What are the instructions? Am I correct? I think if you,
Yeah,
can you, am I correct?
I would like to know the follow-up for this patient with after surgery, when they have been discharged to their home, particularly those who have not well recovered for physiological needs.
Usually, the discharge instructions are explained by nurses only. So we will give a thorough education to the parents regarding what are the signs and symptoms they should look for when they got discharged. For instance, if the child have any fever, look for the wound, surgical wound. If check for any swelling or any leakage or any wound gapping. These all things has to be checked. Plus, if there is any sudden onset of weakness to any limbs or sudden speech, any kind of decreased verbal output or inability to walk or sudden seizures, these are the alarming signs of complications. So the parents, we will teach them these are the alarming signs. If any one of them is there, you have to contact. We will usually give the phone number of the hospital, and we will ensure that it is the number you can call at any time. Plus, how to take care of the child. What is the, in order to prevent the surgical site infection, what are the care they have to take? How to take a bath? Usually we insist the parent to take daily bath simply with soap and water. It is sufficient to prevent infection, but it should be done consistently to prevent infection. Sometimes they may be very fearful. Should the child can take bath or need to put any ointment? Simply there is no need of that. Daily bathing with soap and water is sufficient. If the wound is clean, there is no chance to get infection. This is the first thing we will stick on while giving instruction to them. Plus, the anti-seizure medication, they have to be taken as per prescription. There should not be any situation that the child is not receiving the anti-seizure medication. If the child is in the journey or if the child is in the school, she should or he should take the medicine. It is very, very compulsory. There are a lot of discharge instructions depending upon the type of surgery, but these are the general aspects.
Since we are out of time, I think a session chair can wind up the session.
So thank you, Professor, and thank you, Matron, for giving us the chance to present here. We are very grateful to you for giving the patient. So we have seen that the care of this parents as well as the child with the pediatric brain tumors is very important, because most of the time the parents are worried about the prognosis of that is the main worry of these parents. The prognosis of how will be the prognosis of the child. We have to give full psychological support we have to give to the parents in order to do the follow-up care and all. We have to give all the instructions. Usually we are giving the instructions at the time from the admission itself. We are giving the instructions from the admission time itself. We are giving the teaching and all. And the discharge time also, we are reinforcing that the importance of taking medications and the follow-up care and all, everything we are giving. That's all about the, she has covered almost all the aspects of care.
Thank you very much. A very comprehensive talk, Vijitha. And can I call upon Professor Yoko Kato to give us a few words before the closing? Prof. Kato, you're muted.
So thank you very much for today's two talks. I think Professor Alberto, hope he is with us now. I think you are very experienced, the pediatric neurosurgeon. I think next time maybe you can show us the video of each many cases. I think so. Then we can have more have image the tumors. Albert, are you with us now? Okay, thank you very much. So maybe that we can collaborate in future. And also the second talk, the Sister Vijitha, it was really nice. Most talk is the pediatric field. I think quite different from the adult cases. I think. So I think you have more pay attention of the parents or so many things. I think, but very precise pay attention to the child and also the family or many people. So I think in that means it's a nurse. Nursing is the work is very, very important. So we learned a lot from 2 lectures. Thank you very much.
Thank you, Prof. Kato. Thank you very much for to both speakers. Very informative talk, and we learn a lot. And of course, the nursing part is very vigilant, very important. So after the surgery, so nurses are the ones who look after the patients, and it is very challenging to look after pediatric patients. And we do not forget the psychology support for the parents as well. So this we have to, through experience, as we work, we learn. But nursing care, we can do it, no problem. I think the psychology support is very, very crucial in order to get to ensure parents and children are in recovery condition. So with that, thank you very much to both speakers, the session chairs, and the commentators. We have a very informative session and very, I think all of us learn from each other. We will meet again in the next webinar. Thank you again.